Good evening, everyone. My name is Dr. Olutayo Sogunro, and I am a general surgeon and assistant professor of surgery at Quinnipiac University, the Frank Netter School of Medicine in North Haven, Connecticut. And I present to you today with the Student National Medical Association students at the Frank H. Netter School of Medicine, our Health Disparities in Medicine series. Today's topic is Black maternal mortality. These conversations will be academic, social, medical, and rooted in research, as well as clinical experience in an open forum. Our planning committee consists of 3 SNMA members from the Netter School of Medicine, Mr. John Garcia, Shanae Green, and Madison Masters. They are all class of 2024. Myself, Dr. Olutayo Sogunro, and Dr. Listy Thomas, who is an emergency medicine physician and our Quinnipiac University liaison, but is also an exceptional colleague. Given Dr. Martin Luther King Jr. Day, that was just this past Monday, we thought it was very fitting for us to have this as our opening quote. Whatever affects one directly affects all indirectly. We will introduce our panelists. We'll discuss the first article, followed by a panel discussion, and go ahead and repeat this for our second article, and then open up for questions and answers at the end. So I will introduce our panelists. Dr. Monique Rainford is a board-certified obstetrician and gynecologist. She is a graduate of the University of Pennsylvania and Harvard Medical School. She completed her residency in obstetrics and gynecology at Georgetown University Medical Center, and she is a fellow of the American College of Obstetricians and Gynecologists. She is not only a physician, she's a speaker, an author, and also promotes lifestyle medicine and counsels people on how to improve their health through their diet, exercise, and relationships. She's an assistant professor of obstetrics and gynecology and reproductive sciences at Yale University School of Medicine in New Haven, Connecticut. Next, we have Dr. Veronica Pimentel. She is a board-certified maternal fetal medicine specialist and a fellow of the American College of Obstetricians and Gynecologists. She received her medical degree from the University of Connecticut School of Medicine and did her residency at Boston University and fellowship at Albert Einstein College of Medicine. She is the director of research for the Obstetrics and Gynecology Residency Program and course director for the MFM sub-internship at Trinity Health of New England, St. Francis Hospital and Medical Center. She is also an assistant professor of OBGYN at the Frank H. Netter School of Medicine at Quinnipiac University and the University of Connecticut School of Medicine. Dr. Pimentel is a rising community leader and budding philanthropist. She is the founder of the Cape Verdean American Medical Alliance. Next, we have Dr. Matura Harmon. She is a board-certified obstetrician and gynecologist. She is originally from Dallas, Texas, and attended Baylor University and received her bachelor's degree in biochemistry. She received her master's degree in biomedical sciences at Hampton University and attended medical school at VCOM in Blacksburg, Virginia. She completed residency in Chicago, Illinois, and moved back to Texas to practice. She's an obstetrician and gynecologist at the Women's Hospital of Texas in Houston, Texas. I thank these wonderful and exceptional physicians for taking the time out of their busy schedules to be on our panel tonight. It is an honor to have you as friends and as colleagues, and I'm excited for a great panel discussion tonight. Next, I would like to introduce our student moderators. We have Mr. again, John Garcia, class of 2024, and he is the SNMA chapter president at the Netter School of Medicine. We also have Sydney Miller, class of 2024, and she is the SNMA MAPS liaison, also at the Netter School of Medicine. Both of these students are phenomenal, and I'm excited to turn it over to them to continue to lead our discussion tonight.
Thank you, Dr. Sogunro. So to get started, we just wanted to share a quick fact sheet for you guys. So in 1933, all states reported maternal deaths for the first time, and the mortality rate for Black mothers was 1.8 times the rate for white mothers. These disparities have persisted, averaging 4 times higher for Black compared with white mothers as recently as 1990 to 1996. And the breadth and persistence of these racial disparities, put simply, has made giving birth a uniquely dangerous endeavor for Black women in the United States. As Reagan McDonald Mosley, who is the former chief medical director for Planned Parenthood Federation of America, stated, you can't educate your way out of this problem. You can't help care access your way out of this problem. There's something inherently wrong with the system that's not valuing the lives of Black women equally to white women.
So I can get us started off with the first article, which is titled Racial and Ethnic Disparities in Maternal Mortality in the United States Using Enhanced Vital Records 2016 to 2017. And this was published in the American Journal of Public Health in 2021. And the authors of the study were able to find that maternal mortality for non-Hispanic Black women was 3.5 times that for non-Hispanic white women. And just for the sake of clarity and brevity, I will just be referring to them as white and Black women, and we will be using the language that is found in the paper, even though we fully recognize the inclusivity of pregnant individuals. The study was also able to find that the leading causes of maternal death for Black women were eclampsia and preeclampsia, with rates 5 times those of white women, and a 22.1% contribution to the Black and white disparity. It followed by postpartum cardiomyopathy, obstetric embolisms, obstetric hemorrhage, and other complications of obstetric surgery and procedures. The article also said that if Black maternal mortality for the rates for these 5 causes were reduced to those levels of white maternal mortality, the overall disparity would be reduced by roughly 2/3. For Black women, the risk of late maternal death for postpartum cardiomyopathy was 6 times that of white women, accounting for about 2/3 of the Black and white late maternal mortality disparity. And the article also highlighted that the majority of these causes were preventable, and the prominence of cardiovascular related conditions among the leading causes of confirmed maternal deaths, particularly for Black women, necessitates increased vigilance for cardiovascular problems during pregnant and postpartum period. So the article suggested that many of the complications that led to maternal demise are avoidable, and even stated that the majority of the maternal deaths related to preeclampsia and hemorrhage are preventable, making this a critical area for intervention. If that's the case, and these areas of intervention have been clearly highlighted, Dr. Rainford, could you probably discuss possible barriers to mitigating these complications in these populations, and how could we overcome them?
I want to thank you for the question, John, and thank you for having me here. It's really great to talk about this subject that is very personal to me, very important to me. I actually think one of the biggest barriers is really lack of investment. So when we see that certain things work or Black women need certain support, we need to give it to them. And so when we see that Black women are more likely to have certain complications, then we want them to be followed more closely. We want them to be supported more closely. We want them to be cared by practitioners who are experts in this area. We want them to be cared by practitioners who are sensitive to their needs and will listen to them and will understand them and not dismiss their concerns. We want them to be able to get to their visits regularly. We want them to have support throughout their pregnancy, for example, with doula support. And so we want them to have healthy food in their pregnancy. We want all this support, or they need this support if we really want to make a difference. And so the barriers, I think, is that if the care of Black women does not attract, or it's not believed that it warrants investment, then you find that if they get just enough or like everybody else, but their risks are higher, then how can their outcome improve? Also, when we think about the postpartum part of it, where a lot of deaths happen, I know ACOG has tried to push for 2 to 3 week postpartum checks and more frequent postpartum checks, but it does take resources and support so that those women, there can be outreach to those women so that they can be called back. If they need help getting back to the clinic for that check, they need that support, that continued perhaps doula support beyond that, perhaps nurse visits. So I think one of the biggest barriers is really financial, the investment that is needed to really try to close these disparities. And I think that is a big barrier.
Thank Thank you for that, Dr. Amford. And like Dr. Sogunro mentioned in the chat, if anyone has any questions, you can just place them in the chat and we'll get to them at the end. Since 1993, we have known that there's a significant disparity in maternal mortality of Black mothers compared to white mothers, and this disparity continues to worsen. Dr. Pimentel, given your role as Director of Research of the OB-GYN residency, could you discuss what changes should be made to training programs to promote equity in the maternal health for women of color? And what key factors would you include in any initiative to bridge this gap?
Good evening, everyone. Thank you so much for the invitation. And thank you for discussing such an important topic. The approach to promoting health equity has to come from many different directions. And first and foremost, it has to come from clinical care. You have to provide the right care for the right person, and you have to provide comprehensive and personal care. And it has to come also from education. So one of the educational initiatives, for example, that's happening right now is that CREOC has a health equity curriculum that was started fairly recently, that programs can actually enroll their residents and go through. But in order to provide good education, clinical care, research, and quality improvement projects are very important. So I apologize. This is bedtime, so my kids are crying. So you may hear them in the background right now, and that's the life of a mother. But as I was saying, in terms of research and quality improvement, we're talking about how preeclampsia, 1/3 to 2/3 of deaths are preventable. So one of the ways that we can prevent that, for example, is by preventing preeclampsia. So I'll give you an example of a quality improvement project that we did in our institution. It was an improvement project, making sure we screened everybody for risk of preeclampsia and making sure that we prescribe them low-dose aspirin, which has been shown to prevent preeclampsia. So that's one of the things that can be done, a very simple one, and also making sure that preeclampsia is being diagnosed accurately, and that the woman or the pregnant person is receiving treatment. So that's one level. The other one, I think, is recruiting the recruitment and retention of people of color in medicine, as well as in leadership position, because we do bring a different set of ideas. We bring different experience. We bring, in some ways, different allegiances, right? All of which I think can help enhance the care of women, and especially women of color. And research has shown that when people of color are taken care by other people of color, that they tend to get better care and they tend to adhere to care. So there's a trust factor there. We have to enroll our community organizations to learn from them, to learn how to engage patients, how to meet them where they are. And then one very important thing that I think every single one of us can do is advocacy. So advocacy can start very simply at the bedside. It's talking to your patient, okay? But you can also get involved in your professional associations and societies. What you're doing right now is an example of advocacy, sharing this information with others, hopefully motivating them to participate and be part of change. So one way, for example, that I was very much involved in advocacy last year, which I think has led to some positive changes, and some of you might have participated in this, is I created this petition to ACOG to recognize the contribution of enslaved Black women to the field of OBGYN. Because when I went to medical school, when I went to residency, none of this history was being taught to us, and our history is deeply intertwined with that of slavery in the United States, our history of our profession. And we did not even know the name of these women, Anarcha, Betsy, and Lucy. So that petition actually ended up being part of or inspiring much of a statement that ACOG made with over 20-something organizations, women's health organization, acknowledging the role of racism and wanting to address it. And now we have Anarcha and Betsy and Lucy Days, which are coming up, which I hope you get to commemorate, which is the end of February 28th and March 1st. And I suggested those days because they bridge Black History and Women's History Month. And that is a way to teach others about our history so we don't repeat it again. We can use social media I've learned to navigate social media more and more to for advocacy work and to meet other people or like-minded people where you can bridge across different institutions, different states, even different countries to get things done. And the other work is through legislative work. It may sound a little bit intimidating, but you can write a letter to your congressperson very easily about a topic. Institutions or organizations such as ACOG, they have different things that you can just simply put your name in there, and you can modify the letter or not and send it to your congressperson. But you can also participate in advocacy conferences from your local organization. Specifically, the one that I participated 2 years ago is the one from ACOG called CLC, which is the Congressional Leadership Conference, where you actually get to learn how to speak to your congressperson, your representative, and you learn how to pitch your ideas. You learn the facts. You learn how to share those facts. And an example of that is that we were discussing the extension of Medicaid coverage up to 12 months postpartum as a way to make sure that women could be covered the whole entire time during which women can die from childbirth, right? And to have persistent care and hopefully care with the same provider that get to know them and provide them quality care. So these are some of the ways that we can all work together to promote health equity, maternal health for women of color, and specifically for Black women.
Thank you so much for your answer, Dr. Pimentel. So once a baby is born, he or she becomes the focus of medical attention. When a Black woman expressed concern about her symptoms, it has been noted that clinicians were more delayed to diagnose and treat, and it seems like they're believed less. This happened to Serena Williams when she had to beg for a lung CAT scan in Hebron, and even to Beyonce when she developed preeclampsia. And if it can happen to Serena and Beyonce, it can happen to anyone. Dr. Harmon, could you discuss ways in which expecting Black mothers could advocate for themselves in these situations? And what advice do you have for your peers when it comes to walking that fine line between clinical intuition and unconscious bias?
I also want to say thank you to the students that brought forth this panel, as the other panelists have thanked as well. So happy to be a part of this. To start off, I think that a patient's or a Black woman's best advocacy is in educating themselves. Ignorance isn't bliss when it comes to childbearing. Education is very important. We're so fortunate that within our specialty, things go right. Because when they go wrong, it can be extremely catastrophic. So in these situations, like you mentioned, with Beyonce and Serena Williams, I think that just education comes in the prenatal phase, because if we're already at a situation where the patient's being ignored or not being heard, we're too late. And so, as I mentioned, just utilizing your physician to educate yourself is going to be very important. I think patients don't ask enough questions, so don't assume something. Our friends, our family, Google, all these things have a wealth of knowledge, but if you speak with your doctor and ask questions, we know your circumstances, we can tailor our answer and our advice to the patient themselves. If something's unclear, then ask for clarification. It's terrible when patients get lost in the translation of medical language or in misinformation. Also, as I mentioned, that if you are educating yourself and getting that information in your prenatal care, that's an opportunity for you to get a realistic expectation, especially if you're a first-time mom, to really understand what your prenatal or antenatal care is, what labor and delivery is about, what your postpartum course is. You have an opportunity to develop a birth plan so you know about the risks that go into spontaneous labor and waiting versus induction, how a labor course can change from vaginal delivery to a C-section. You have the opportunity to, discuss what some complications can be in terms of diagnosis, such as preeclampsia and so forth. And as she mentioned, having a doula, how this person can also advocate for you, how your spouse in labor and classes can also advocate for you. I think all these things are very important for patients to do early on so that when that time comes, they have knowledge for themselves or through their partner or a doula who can also speak on their behalf. Also, I think very early, knowing your family history. If a family member has gone through something, particularly your mother or a cousin or a sister, that's something that you can also bring up within your care so that your providers can be vigilant about and prepare for. The second half of the question, I think, how do you talk to your peers about that fine line? It's a little bit harder because this is an area that goes unrecognized by us. Your clinical intuition is a instinctive, unconscious action that you make without judgment, whereas the unconscious bias, you have some type of, attitude or discrimination against something. And so for me, I always tell my patients that their concerns are my concerns. So I think that if my peers have this mentality, we're kind of looking at things from a different lens. It's a little bit more personal versus subjective as to like the patient is saying this or the patient is complaining about that. If we really adapt their concerns as our own concerns, we're taking maybe just a little bit more of a introspective look at what their concerns are, and there's a little less bias that I think comes about if we're looking at it from that lens.
Thank you so much, Dr. Harmon.
Okay, so moving on to our second paper for tonight. Just before I read the quick summary, I'd just like to remind everybody, if you have any questions, please put them in the chat, and we will have about 10 minutes at the end for a Q&A session for all three of our panelists. But the second paper that we will be discussing today was written by Dr. Elizabeth Howell, titled Reducing Disparities in Severe Maternal Morbidity and Mortality. This was published in 2018 in the Journal of Clinical Obstetrics and Gynecology. So in this study, Dr. Howell found that Black women have had the fastest rate of increase in maternal deaths between 2007 and 2014, and maternal death rates have risen up to 12 times higher in some cities for Black women than white women. The data suggests that there are a web of factors, including a higher prevalence of comorbidities and pregnancy-related complications, lower socioeconomic status, and less access to prenatal care. These all contribute, but do not fully explain the elevated rates of severe maternal morbidity and mortality among racial and ethnic minority women. Adjusting for the socio-demographic and reproductive factors has not explained this gap in pregnancy-related mortality. Additionally, racial and ethnic minority women are more likely to have many chronic illnesses, including chronic stress, that places them at a higher risk of severe maternal morbidity and mortality. Studies have shown that Black and American Indian or Alaskan Native women report the highest number of stressful life events in the year prior to birth, and higher levels of stress self-reported and biologic measures of chronic stress have been reported for Black versus white pregnant women. Additionally, hospitals that disproportionately care for Black deliveries have a higher risk-adjusted severe maternal morbidity rates for both Black and white women in those hospitals. If Black women delivered at the same hospitals as white women, nearly 1,000 Black women could avoid severe morbid events during their delivery hospitalization, which would decrease the Black severe maternal morbidity rate from 4.2% to 2.9%. So this paper references a study that was conducted by the Society for Maternal Fetal Medicine that states that 84% of respondents agreed that disparities do impact their practice, but only 29% believed personal biases affect how they care for their patients. So I'd like to direct this question to Dr. Rainford. Could you provide a specific scenario where you believe personal bias may have affected the outcome for a mother of color?
You know, that statistic is the disappointing thing when you think about it, because if people think, well, I don't do that, then they're still totally unaware and it is unconscious, and it perpetuates the cycle because they are given less quality care and they're just not aware of it, and they really believe that they're given equitable care. One example that I can think of, actually a very powerful example, is the case of Kira Johnson. Her husband, Charles, continues to advocate for her. She died years ago because she was at a well-respected, well-resourced hospital. She had a complication post a cesarean section. She had active bleeding that her husband noted. He advocated for her over and over and over and over again, over hours. She was ignored. And what was really tragic is that her husband was told by one of the caregivers that his wife was just not a priority. By the time they took his wife back for care, it was too late. She had bled over 3 liters of blood into her belly, and she died, her abdomen, and she died. When you think about that, she was educated, well-resourced, she knew what to do, she had advocacy, she had all those things in her favor. Yet, when you look at it, she was allowed to die because she was not given the attention she needed or she deserved. And that is just one of many examples where the care of Black women is compromised because they're not listened to or believed. I had an example of a patient I took care of a few years ago, but I was taking care of the patient, and she was a Black woman, and she had some symptoms of nausea, vomiting, which frankly would warrant evaluation, some lab evaluation. I remember the nurse telling me, well, she looks fine. She doesn't look like she has any problems. And I thought to myself, she doesn't look like it. She said she had a problem. So I did some lab tests. We found out that she had electrolyte abnormality, that she actually had to stay days in the hospital to improve, and it could have had serious consequences. So this thinking of a patient doesn't look like they have that problem, they don't look like they're in pain, they don't look like they need help, not believing, that's a problem. And I do know that some of the people who are responsible for that really don't have bad intentions, but that's not good enough. That's not good enough not to have bad intentions. We as clinicians need to be more aware of our biases. We need to learn about implicit biases, and we need to learn how to cope with them and to counteract them as we take care of our patients, so that we can truly give equitable care to our patients, so that we can begin to reverse some of these trends.
Thank you so much for sharing those stories with us. For every maternal death, 100 women suffer a severe obstetric morbidity, a life-threatening diagnosis, or undergo a life-saving procedure during their delivery hospitalization. And Black women have the highest rates for 22 of 25 severe morbidity indicators. And so, Dr. Harmon, there seems to be a misconception that there is a biological reason for these health disparities. How can we educate the future physicians that bias in maternal fetal care is rooted in racism and not defaulted to our biology?
I think that we cannot divorce ourselves from the notion that biologically Black women are at increased risk of chronic diseases such as heart disease, stroke, cancer, diabetes, things of that nature. But what's important to recognize is that the morbidity and mortality disparity is not in the diagnosis, but it's in the quality and access to care. So similarly to what was just said, is that we can't look at a patient and say she doesn't look sick or make assumptions without thoroughly evaluating the patient. And so the whole conversation about our unconscious biases, I think that's what's the most important thing for our future physicians, just recognizing that we all have a different nature and nurture. We all have different cultural backgrounds. And, just because our background is different from someone else and we may not recognize things, we need to learn to educate ourselves on other cultures and some of the biases that we may have based on our nature and nurture. And so I would implore future physicians to not ignore this conversation about social biases and really take an introspective look into, yes, different communities of people, Black women in particular, we do have certain chronic diseases that are prevalent in our communities, but how can we best serve these people is by educating ourselves and, giving quality and equitable care to everyone.
Thank you so much, Dr. Harmon. Many racial and ethnic minority women are unfortunately not referred to a maternal fetal medicine specialist despite having chronic conditions, including chronic stress, as was mentioned earlier, that places them at a higher risk of severe maternal morbidity and mortality. And so, Dr. Pimentel, as our maternal fetal medicine specialist on the call tonight, I would like to ask you, how is limited access to quality healthcare a critical reproductive justice issue across the life cycle from birth until death?
Thank you so much for that question. So let's start from the premise that all women, regardless of color of their skin, race, ethnicity, income, geography, should have the right to make informed decisions about their reproductive and sexual health and should have access. I think we have to start by distinguishing reproductive rights from reproductive justice, which I think your question in some ways is implying that there is a distinction there, and there is. The reproductive rights have to do with the legal rights to access reproductive healthcare services. However, if you have the right, but you don't have access to the care, then that's not good enough. So just having the right, for example, one thing that we talk about often is if a woman may have the right to an abortion, but if she doesn't have access to it, it doesn't do her any good if what she needs is an abortion. But so what we're seeing more increasingly is that there is a tearing down of reproductive justice, meaning that there's restriction to access to care. And it's coming, for instance, the way it is affecting obstetric in many ways is in many rural parts of America, and that includes Connecticut. Hospitals are cutting down some access to labor and delivery. So there are a lot of closures of labor and delivery. So, and even when labor and delivery units remain open, they may be providing reduced breadth of services. For example, they may not be providing birth after a cesarean delivery. They may not be providing cesarean deliveries at all. So I believe since 2010, about 130 rural hospitals have closed. And right now in Connecticut, there's discussion about closing one. And this is leading to increase in births without proper obstetrical care, and is leading to preterm births in rural areas. And when you close also a hospital, you don't have access to your general obstetrician, to your midwife, but also you don't have access to higher level care, and you don't have to NICU, and you don't have access to maternal fetal medicine specialists. So it's a compounding effect. So when the closure of these services is actually happening more in areas that have higher rates of Medicaid coverage, higher rates of poverty, higher rates of people who are either Black or Indigenous. The very populations that we're talking about who right now have the highest rate of maternal mortality and morbidity. So by closing these units, this is leading to lack of access, and birthing people may have to travel very far to get services. And this is compounded by the fact that access to reliable transportation in many of the areas is limited. So now that's one issue on top of another issue. So the problem a lot of times is, yes, in many times where Black and Indigenous people are delivering may have a higher mortality rate, but at the same token, when you have a hospital in your community, providers there tend to know you better. They tend to understand the community. They invest in the community. If you now have to travel an hour or 2 hours, people don't know you as well. And that has been shown to lead to increased maternal mortality. I believe Pennsylvania was one of the areas where this was studied, and it showed that it increased the rate. So access to quality care is very important. And without access, even if you have a certain right, it's not good enough. The right is not good enough. You have to have access to care. And part of the reason why these hospitals are closing is that it's because of economics, and also sometimes not even having enough practitioners who are willing to practice in these hospitals in rural areas. And COVID is adding more to the issue right now, where more places are trying to close as we speak, and this is likely going to exacerbate a problem that we're dealing at the moment.
Thank you so much for that answer, Dr. Pimentel, and thank you all of our panelists for your answers to our questions that we've asked today.
Yes, thank you so much, everyone. We are going to move on to our question and answer session. What we'll begin with is questions from the chat and any additional questions sent to us. And then we will actually open up the forum for anyone that wants to just actually direct questions into the chat and speakers. So I will turn it over to Shanae, who is going to moderate our question and answer session.
Thank you, Dr. Sogunro, and thank you to all of our panelists again for joining us. So we'll start with the questions in the chat, and the first one says that, okay, so oftentimes patients do not know what questions to ask. How can providers find balance between office hours, clinical hours, and providing education? What steps can be taken to foster a collaborative relationship between doulas, childbirth educators, nurses, and lactation consultants? And that question is open to any of our panelists.
I think that it can be very challenging sometimes, especially if you're a first-time mom, to know what to ask. There are many educational books out there. I think it is up to us as providers to also provide our patients with information and questions. And part of our job is to educate, even if it's 15 minutes, but you can do a lot there. There are ways to go about enhancing that. It doesn't work for every single patient, but you can have videos in your waiting area. You can have booklets. You can have childbirth classes, lactation classes. You can collaborate with other professionals to make sure that you're enhancing the care of the patient. And the other thing is to also educate the support person, the partner, the patient's mom, sister, whoever is part of her inner circle of support. And I'm going to mention there's one thing that I think is very important, and all of us should know about this, is that the CDC came with this campaign called Hear Her. So those are the signs that we should be aware of. For example, if somebody's having a headache that is not going away, could that be a sign of preeclampsia? So those are symptoms that are easily recognizable. A partner can actually go through that and be like, my wife, my girlfriend, or is having these symptoms, let me contact her doctor. So that's one of the things that has been done in order to try to reduce maternal mortality, to make sure that partners and significant others and family members can advocate for their pregnant person. But yes, I think it's not just the role of the person, the OBGYN or the midwife who's seeing the patient for that 15-20-minute visit, but you have to enlist other care professionals to support that education, to support the care, and be able to help the patient navigate a very complex system that we have here in the U.S. for maternity and for birthing.
I agree with all of that. In my practice, we have like first, second, and third trimester packets. And so it just provides a lot of reading material for patients. And my EMR system also has patient information that we can give to patients after each visit. So it'll say like from weeks 18 to 22. And so it'll give expectations of at your next visit, we'll do like your glucose challenge test and things like that. And then also having just different posters on the wall and things like that can spur conversations for patients to ask. And also just simply asking like, what questions do you have or what are you concerned about? That can also help, help to spur a conversation just briefly as you're listening to your fetal heart tones or something like that. Sometimes it doesn't have to be a long drawn out conversation. It can just be a quick question as to like, what concerns do you have? I think in terms of the collaborative relationship between doulas and childbirth education, nurses, lactation consultants, I think for us just continuing to educate ourselves and utilizing one another, there's some systems that, midwives and doctors don't really work together as well, or doulas seem to be interrupting inpatient care sometimes, going a little bit beyond advocacy. But I think that if we, all try to work together and keep the patient in mind, that we can have a very collaborative educational experience for our patients.
And I think you can really explore what your community has to offer. For example, in Connecticut, there are doulas for Black women. And so as a clinician, you can get to know the doula services, get to know the doula herself and who provides services, and try to share this information with your patients. I think you can do that throughout communities. You can vet the services beforehand. You can use, like, say, the National Birth Collaborative organizations who promote these to find the best doulas in the area where you are, for example, so that you can build those community relationships. And if you build those community relationships, I think that will enhance the care that you deliver to your patients. Because yes, your patient might not think of everything to ask you, but they may think of something to ask their community outreach people or their doula, and then, or they can bring the question back to you. And you, even if you can't talk to the doula directly, that can help them bring more questions to the table so that you can know how to take better care of them by the questions they ask. So I think really building those relationships wherever you're based, just seek them out. And I think you'll be able to find more and more people who are willing to work with you to help take care of your patients, your pregnant patients.
Thank you all for those answers. The next question in the chat says, what role can doulas and other community health workers play in care quality and preventative care? If these health workers can prevent expensive complications, wouldn't they save insurance money if they were funded and prescribed to patients, especially in the postpartum stage where a lot of mother and newborn complications arise?
There is research that supports that doula support can reduce complications for both mother and baby. And yes, there is evidence that supporting this can reduce outcome. It's a matter of, I don't know if we need more data or we need more convincing or we need more training of doulas or all of the above, but there's certainly information that suggests that can be helpful. And what Dr. Harmon mentioned earlier, it does need to be a collaborative relationship. It can't be one camp versus the other camp. The doula does need to work with the clinician, but be an advocate for the patient first and foremost, but in a collaborative way and not a sparring or confrontational way. And sometimes those relationships can be difficult to maneuver, especially if the clinician is not comfortable with a doula, but I think it's certainly worth it. And I think that if a pregnant woman has that doula support throughout the pregnancy and the postpartum, where she really doesn't have much checks with her clinician after delivery, but she still very much needs that help because, again, a lot of maternal deaths occur at that time. The doula could be that point person, or that community caseworker could be that point person who brings her to the attention of her clinician, or lets her know that you have to go to your clinician, you need this care, you have this problem, and this is what you have to ask. So I really think that more needs to be done to bridge a gap. And I do think these programs should be supportive, and we just need to keep advocating for more support for these programs.
Absolutely. Talking about advocacy, there are bills that, for example, have been, that I believe at this moment in time, are still being considered by the state of Connecticut, where you can provide support. So you can write to your congressperson and ask them to support that. I was actually trained in a very collaborative model. So for some of you who are contemplating going to obstetric and gynecology, I look at Boston Medical Center as a model. So what I loved about that is that we were a collaborative model where in labor and delivery, there were obstetricians, family medicine docs who delivered, as well as midwife. Midwives were actually our attendings during our first year as interns, and then we became their consultants when we became chief. But more importantly, we had doulas. So we did not call them doulas, we called them birth sisters. What they came in handy in so many different levels. First of all, it was supported by the institution, I believe via grants money. So it did not matter what income the patient had. But many of the birth sisters came from the local community of the patient. We had such a high number or rate of patients who came from different parts of the world and spoke different languages with different cultural practices. They served in some ways as our cultural ambassadors. There are many, so they understood where the patient was coming from, they understood the culture of the patient, they understood the language, and they served an invaluable role in helping us promote equitable care for all of our patients. So absolutely, there are models out there that have been shown to work and to work well, collaborative models, and we should all be working with the patient being in the center, and we should all know the role that we play. We all have a role that we play. A doula is not a physician, and I'm not a doula. So we have a role that we play, and together we should be playing it to make sure that we take excellent care of our patients.
And I'll get on my soapbox about insurance, the insurance industry. I feel like in medicine, the insurance industry is definitely becoming more and more intrusive. And in some ways, I feel like us as clinicians are losing a little bit of our autonomy sometimes in how they are directing our practice in so many ways. So I think lobbying, speaking to our representatives will be very important as we go forward, because sheer economics and just, I feel like insurance kind of taking over really is in many ways limiting, some of the care that we can give to our patients in terms of the roadblocks that they put up because of the economic component of it. So I do wish that patients did have more access to, the doulas and the educators and lactation consultants. And oftentimes insurance does limit it to one postpartum visit with the lactation consultant, when that can be an ongoing process. So I think as a whole community of patient and physicians, we should try to lobby to try to gain more access for our patients in terms of access to other resources beyond just the clinicians.
Thank you guys for those informative answers. The next question in the chat says, can the speakers speak about any experience they have with PAs and NPs and how their roles can help to expand access to care?
You find, again, with insurance and different models, PAs and NPs are very important in delivering care. I do think I found PAs the PAs I've worked with are mostly in a hospital setting, and in one of the hospitals I work with, the PAs were our assistants. We didn't have residents at the time, and the PAs assisted us in surgery and helped us enrolling patients and keep us informed of the patient. And I thought that was a very great collaborative relationship where we work together in the patient's interest. And I think that definitely has a place. And I've worked in NPs in different levels. And I think that when you have a good collaborative relationship, you know that if the patient is high acuity, you refer that patient to the physician. The NP can triage, or even if they have a complicated case, the physician is right there so that they can discuss it with them and work closely with them, and knowing when perhaps some patients might be more appropriate for a physician versus an NP. But having that collaborative relationship can increase overall access. It is necessary with cost and everything else to have everybody, and with actually just resources. We need everybody to contribute, but I think we just have to make sure that everybody is doing their role that they can do best, and everybody is being utilized to the top of their license.
Thank you so much, Dr. Rainford, for answering that. That was excellent. And thank you to all our panelists. This has been phenomenal. I would actually like to just open up the floor to see if anyone wanted to share any questions or comments. I believe there was someone in the chat, if she's comfortable sharing a story she wanted to share with the group. But we just wanted to have a little bit of an open forum for people to kind of jump right in and ask some questions and share stories.
Thank you so much. I was the one that wrote that about the program. And I really want to thank everybody for coming together, because I think this is such an important topic, especially like now, today. I think there's so much more awareness, but we still have to create more awareness. I just moved, and I am a faculty member in the School of Nursing at Quinnipiac. I moved from New York City. NYU was just a medical center that grew and now has more it became a system. But right before I left, we had just created a program where now patients, it's an automatic order for postpartum families. If they're breastfeeding, they can actually reach out to us, and through telehealth, because of COVID, we're now able to expand our services, and it's covered by insurance. So I think when we're talking about investment, and you were talking about before, I'm sorry, Dr. Pimentel, about, your experiences at Boston was collaborative. I think more hospital systems have to really look to collaborate. How can we together work so that we can do better for our patients? And just on the flip side of that, we were just building our doula program. And unfortunately, something happened where now the institution has said, nope, we need to put money elsewhere. So this was again, it has to do with investment. So, you take 2 steps forward and you hope you're not going to go backwards, but it's a process. And I think as physicians are learning, we have to all work together, nurse practitioners, physician assistants. I'm also a Lamaze certified childbirth educator and a board certified lactation consultant. All of these people are incredible resources for families, and not every one of us is looking to make a buck. A lot of us are doing it because we're passionate. So not being, I think my experience has been as a nurse, sometimes doctors hear the word doula and they go, they cringe. And I'm like, don't cringe. If anything, it's going to lighten your load. If you've got the right, I think sometimes the attitude that we take, but I think it's about investment. As well as investing in this session, but the money behind the systems and insurance carriers make it very difficult for families. That's a huge obstacle. Thank you.
Thank you so much for sharing that. And by the way, I understand a little bit of your experience having been trained at Einstein and know the difference between Connecticut, New York, and here, where there were no midwives in my fellowship, but there were PAs, for example, and it's a long story, but the key is investment. I think Dr. Rainford also mentioned that. If you look about investment and return and payment, when it comes to women's health, the society does not invest in women's health. Okay, we are in a patriarchal society. We deal with sexism. It comes down to medicine. Okay, one of my residents actually published recently a study looking at pelvic floor surgery. Okay, reimbursement for male physicians versus female physicians. Female physicians were under reimbursed compared to male physicians. So there are many, many stories that are much research that has been shown that investment when it comes to paying women or investing in women's care is very limited. So we have to commit as a society investing in women's health care, or not just women's health care, pregnant people, because many people do not identify themselves as women, but birthing people invest in their health care and reimbursing people adequately. You know, when you're not, obstetricians many times are not being reimbursed appropriately. And then when they hear that a doula is being reimbursed X amount, it feels some kind of way for many of them. And I think then it creates this infighting as opposed to actually trying to help each other. So I think that if society invests in women's care, in birthing people's care, then many of these issues would go away, you know. And the reason why one of the reasons they might have, I don't know your exact story, but they might have cut down that program is because there was no real money coming back directly that could account for. You know, it's all about the dollars and cents at the end of the day. This is what I'm learning after many years in medicine.
I think you are right on target regarding that. It's what's the return on investment, the ROI. Absolutely.
And think how much money would be saved if some of those hospital costs were saved, some of those complications, if those babies did better. There's so much money to be saved by investment. We just need to advocate so that we can convince people that you can save so much money in the long and short term with just some more investment.
Very true. Thank you guys so much. Does anyone else in our forum tonight want to say or ask any questions or make any comments?
All right. So then, just in case, because I know that sometimes Zoom likes to play games with us when we end things right on a time, I would just like to bring us together and close it up. And thank you again so much for coming. And thank you to our panelists. It was a really excellent and interesting discussion. And I feel like I learned a lot. I'm very excited for the next one, which will be on Black skin and dermatology on February 24th, also at 7:30 p.m. There's a QR code there. Please feel free to scan it and register for it now. And additionally, as a part of this series, we would really ask that you could complete a quick post-event survey just to help us better understand the demographics of our audience and the impact that it's having. We'll also be emailing out a link to this survey later, and we will be, redistributing links to register for the next Health Disparities series event as well. And we hope to have you all there.
Thank you so much, Madison, for closing us out. And thank you, everyone. Thank you to our wonderful panelists, Dr. Rainford, Dr. Pimentel, and Dr. Harmon. You embody so much of what we need and where we need to be when it comes to Black maternal fetal health. So I thank you all so much. And I thank all the students, physicians, clinicians, everyone that was on the panel today. And I really just hope that this panel series has kind of given us some perspective and, really allowed us to kind of think about our role and our participation in maternal fetal health, and really for us to be the change that we wish to see in the world. And by participating today, you guys started that journey. So thank you all so much. Thank you to the wonderful SNMA students and future colleagues of mine. You guys were phenomenal, and we'll stay on as a group after this just to kind of talk a little bit and get our group photo in. But everyone else, thank you so much. Have a great night. And if you all have any questions or anything, feel free to email us. I will put my email in the chat to everyone. My name is Dr. Olutayo Sogunro, and if anyone is interested in, kind of doing something like this at their own facility or their own hospital or university system, I'd love to work with you in some way, shape, or form to get this started. I want to be the change that I wish to see in the world, and this is part of it. So I would like to help anyone else that wants to do that. Let's change the world. So thank you all.
Thank you so much. I just want to say one last thing. If any student is interested in participating in research, please feel free to contact me. We're doing a lot of wonderful things at St. Francis, and I'm happy to partner you with a mentor, or you can work directly with me as I'm doing the project. So reach out.
Thank you. Have a good night.
Have a great night, everyone.